Hi everyone, my name's Rory. I'm a haematologist. I work mostly at North Shore Hospital, a little bit at Waitakere, and just setting up some private at Harbour Cancer Centre. So CLL is sort of what I like. Everyone likes something, right? And that's what it is for me. I've kept it pretty lean intentionally for today, so 10 minutes will fly by. The first section, I guess, is just on sort of basic scene setting. The next, hopefully, is something that is relatively familiar to you, but ties in a little bit with what we do in terms of treatment. And then there's a couple of kind of nuggets that I really wanted to impart regarding immune dysregulation in CLL, and just some things to look out for in terms of some of the novel therapies that we're prescribing these days. So MBL, monoclonal B lymphocytosis, is sort of like the MGUS of CLL, if you like, sort of pre-CLL state. We think that all CLL comes via a monoclonal B lymphocytosis, whether it's recognised or not. And when it becomes the fully fledged disorder, we call it CLL. The terms CLL and SLL we think are interchangeable. They arise from the diseases of the same cell of origin. And what those two terms are describing is really a spectrum of disease, one at the leukemic end and one more at the lymphoma end. But it's quite common for CLL to have lymphoma-like features as well. I think the diagnosis of CLL is, we get a pretty handy clue half the time in terms of the lymphocytosis that appears in blood tests. And I mean, it's kind of a pointed, obvious marker of abnormality. And there's a handy test that you can do called flow cytometry, which will characterize the absolute lymphocyte count. And if we're looking towards a diagnosis of CLL or SLL, then hopefully it will give you a clone, which is a subpopulation of that total lymphocyte count. And that clone, obviously, all the cells all look the same. Having a clone of B cells, which is abnormal. Not all clones of B cells are CLL, it must be pointed out, but the vast majority will be. And importantly, the distinction between MBL and CLL is kind of numeric. So the clone will look the same. They'll describe a CD5 positive B cell population co-expressing a number of different proteins, which I'm sure you gloss over pretty quickly. But the point is it's all about quantitation. So if that clonal size is more than 5, we're forced to call it CLL. And then I'm talking about the peripheral blood here. If it's less than 5, we're forced to call it MBL. But a lot of MBL will have associated SLL features. So the point is these three terms are somewhat related. CLL and SLL are kind of interchangeable, and there's the quantitation of the B cell clone is important in the peripheral blood. We try not to treat CLL, and I guess a big important statistic there is that 30 to 50% of diagnosed patients will never need therapy in their lifetime. And I guess that's really important to understand when you're seeing someone in the community for the first time, that you're not necessarily giving them a doom and gloom diagnosis. We never treat MBL. There's no reason to do it. It doesn't. Early intervention in MBL and CLL does not make a person live longer or live better. And that's even with newer therapies available. So we follow a sort of the IWCLL treatment criteria in terms of making decisions about treatment. And I guess the most likely scenario is we'll get people who are referred from yourselves and end up in our clinics, and we may still watch them for a little while, often for a long time before if we do offer them any therapy. And kind of the sort of broad categories of treatment indications sort of fall under advanced or bulky disease. And that might cause a patient to feel crook in terms of feeling fatigue, developing night sweats, having fevers. They may be experiencing bulky lymph nodes through their bodies. Some people find that cosmetically disfiguring, obviously, and at times otherwise it can just be really annoying. But bulky inguinal lymphadenopathy is no fun. Unusual disease, we see it, normally it's in the blood and lymph nodes and bone marrow, but we do see it in extranodal sites, and that's often an indication for therapy. And then there's the cases where you establish a patient's got CLL and you just watch their lymphocyte count go rampant over the course of a short time period. So we do use this idea of the lymphocyte count doubling within 6 months as a reason to treat. This is a snapshot of the health pathways referral, and I guess I just wanted to marry up some of those ideas along with what you're seeing in the referral criteria. As you can see, there's significant symptoms, constitutional symptoms, fatigue, reducing performance score, kind of go with that idea of constitutional symptoms. Symptomatic lymphadenopathy or hepatosplenomegaly fits with that idea of disease bulk, as does, this is kind of an interesting one for me, but nodal disease in 3 of the 5 sites, which I'm knitting that all together, but I guess just really it just fits with more nodes involved, the more advanced CLL is likely to be. When patients becoming cytopenic, so usually that represents bone marrow failure from CLL crowding out the bone marrow, but we do also see, importantly, there's autoimmune cytopenias that exist. So we see warm autoimmune hemolytic anemia, we see ITP in the setting of CLL. We can actually treat those without treating the CLL in the first instance also. Or if you see a progressive lymphocytosis, that again fits with that idea of rapid disease kinetics. But importantly, again, have a careful look at what you're seeing in the report of the flow cytometry if you've ordered it, because not all of these things will be CLL. And if it isn't CLL, but they identify a B lymphoproliferative disease, we'd like to know about it, please. I might just skip over that because it probably is important. I hope these are useful things for you. So what we see in CLL is that the immune system is quite impaired because of the CLL itself. And those abnormalities that can be demonstrated in pretty much every compartment of the immune system are then amplified if the patient receives therapy. I guess the 2 important things here are a patient can have very low immunoglobulins as a result of the having CLL or MBL. And you'll see that. You might see pan-hypogammaglobulinemia where all of the immunoglobulins are suppressed. And we also see, importantly, that T cells are really quite dysfunctional in people with CLL. And that leads on to 2 pretty important associations. Importantly, we see this immune dysregulation even when a patient has very early stage disease. So just making a diagnosis of MBL or CLL should prompt you to consider these ideas. We know that infection is the leading cause of mortality for people with CLL. We know that vaccinations are incredibly important and likely to offset some of the potential for morbidity and mortality from infection. So the 4 kind of, I guess, organisms that have been identified as something that you can vaccinate against are the Streptococcus pneumoniae, which obviously is, I think, still non-funded, COVID-19 vaccinations, and importantly, multiple COVID-19 vaccinations because of the sort of impaired seroconversion that will come with immune dysregulation. Making sure the patients are getting their annual flu vaccine, and now Shingrix should be available for all patients with CLL. Now, these are all non-live or attenuated vaccines, and live vaccines are contraindicated for people with CLL for safety reasons. It's important to consider that recent therapy that is suppressing of the immune system, and that's really what CLL therapies are, is potentially going to impede the ability to respond well to these vaccines. So we think carefully about the timing of them. And sometimes for patients with recurrent infections, we may end up prescribing them monthly IVIG prophylaxis, so replacing those immunoglobulins to try and offset some of that infection risk. We wrote this consensus guideline last year, which summarises some of those ideas quite nicely, and you can find the references for each of these concepts in that paper, so I'll just put that in if you're interested. The second important complication of immune dysregulation is that of secondary malignancies. So patients with CLL have much higher rates of getting a second cancer than patients without CLL. And again, that goes for MBL and CLL. It's quite hard to give you numbers because it depends on the length of follow-up of cohorts and studies and which patients are selected, but that's I've just put a series of 500 CLL patients in Australia, and over the course of their follow-up, almost half of them have developed a second cancer, which is higher than what you might expect in the general population. And this risk signal is particularly striking for skin cancers. So that's basal cell carcinoma, squamous cell and melanoma, and that's particularly enriched in Australia and New Zealand for obvious reasons. We see it a lot. You know, a lot of our patients in the clinic will constantly be coming and getting things cut out and coming back, and I'm sure you guys will see it far more than we will in our clinics. But it's significant, and you know, we do get patients who have breakthrough metastatic skin cancers whilst they're being monitored for CLL or on CLL therapy, and obviously it causes significant issues with survivorship. We recognise that this is just because of having CLL, but then patients that have had chemotherapy, particularly those rates of secondary malignancies go up even higher. So there's a couple of things that we recommend generally, which is that patients with CLL should undergo an annual skin check where possible. I haven't been making any specific recommendations about how that's done, whether it's in primary care or this is via private providers or self-funded skin clinics, but just having an annual skin check is really important. We recommend these patients are very vigilant about their physical symptoms in terms of suggesting a second malignancy. And from your side, it's really important that patients with CLL are engaged in all age-appropriate malignancy screens to try and offset some of those risks. I'll keep this quite short, but we're using small compounds now to treat CLL. Ibrutinib, acalabrutinib, zanubrutinib are what we call Bruton tyrosine kinase inhibitors, very effective drugs. The important side effects are that they can cause bleeding, atrial fibrillation and hypertension. And those last two are actually cumulative. These patients will remain on these therapies for years, and it might be 2 or 3 years after starting treatment that a patient has unexplained breakthrough hypertension. So obviously I think it's something that you'd be interested in and will probably come to light, I would imagine, in community care before it comes to light in our clinics. There's also important implications for concomitant medications that might be prescribed alongside them, including the implications with both bleeding but also the metabolism of these drugs. And venetoclax is another compound which sort of has something called tumor lysis syndrome as a risk associated with it, but it's probably more in our sphere than yours. But again, also has important drug metabolism complications. Leave it at that. Thanks very much.